And because of that, I'd like to go back and review just a few things. I'm not going to do a whole lot of the anatomy. There's a couple of key points that I want to talk about very briefly to go back over. Key points to our lecture is the bronchioles have a smooth muscle layer and lose the cartilage support, which that smooth muscle layer is one of the sources of our problems in dealing with patients in respiratory emergencies. I feel like that's a key point. Another thing I want you to remember about the alveoli is that they have a tendency to collapse. We talked about the surfactant that's produced, and the funny thing is scientists don't really even know why or how, what mechanism the body uses to know to produce this surfactant that keeps the alveoli from collapsing, because it is their natural thing to do. Not to jump ahead, we get a little bit ahead here. When we're talking about adult respiratory distress syndrome, things of that nature, we're going to talk about positive end expiratory pressure, or PEEP, as you'll hear it. The whole point of that is to help prevent the alveoli from collapsing, as they have that tendency to do.
I really, really like being able to stop time like that. It's very empowering. I also like the fact that when I can make words appear here, or even here, if I want to. They are up there, aren't they? Okay. But I didn't stop it just to play with my superpowers. I wanted to remind you, this is from 2002, and I mentioned PEEP and positive end expiratory pressure. A little later on in this, I'm going to tell you that it's not been a skill very long. That was a misstatement. It had been a skill for a long time. The thing was, we just didn't have a lot of use for it in the adult patient. I can tell you that what pops immediately into my mind when I think about PEEP was near drowning victims, that water had gotten in the lungs, washed away the surfactant, and we were ventilating them with a bag valve mask, and we wanted to keep some positive pressure in the airways to keep the alveoli inflated so that they didn't have a chance to collapse. And you still have that option. A PEEP valve was either a valve that you attached to your bag valve mask, or sometimes the bag valve had a PEEP device built in. Those were the ones that you found at your finer bag valve mask stores in any mall. But some of them had it built in. We just didn't use it a whole lot. Later on, and when this was made, continuous positive airway pressure, CPAP, was in use. It just really hit its stride. It wasn't. Some places didn't have it. It was not commonly used, but it was making headway. We use that. We have several applications for that. It is a common part of our protocols for treating CHF and some forms of pulmonary edema. And if your near drowning patient is breathing, it probably do them some good too, because they've lost that surfactant. Atelectasis is quite likely, and keeping some pressure in there, keeping those alveoli at least partially inflated, prevents that from happening. So I just didn't want you to think that I had forgotten our old friend CPAP. As a matter of fact, not right now. And at some point, we'll probably do a demonstration, both in the classroom and, of course, here on video. One more thing before I go, and I don't know if I apologized on the other videos. If I did overlook this, but if I didn't, forgive me for battling a cold. I listen to these things while I'm putting this together, and I'm sniffing. You can't help it. And the more you talk, the worse it gets. And it doesn't sound that bad when you're lecturing. When you're listening to it, it sounds like a howitzer, and I apologize for that. So without just want to touch on that, kind of bring you up to speed. Hadn't forgotten CPAP. We will talk about it, how it works. Oh, one more thing about the both PEEP and CPAP. One of the problems with PEEP is that in some patients it causes a decrease in cardiac output. You had to use it with caution, and we'll talk about the mechanisms of why that was. Bad news is CPAP can, in some patients, cause the same problem. If that's the case, then we need to look to CPAP sibling BiPAP, which is not commonly used at this point. There are, I think, some agencies that are experimenting with BiPAP. Some of your critical care transports, of course, have it. But we still mostly are CPAP. BiPAP's on its way, I'm sure. So just wanted to make sure you knew that. And having said that, I'm going to use my phenomenal superpowers to allow time to start moving again. And I will make my way out of 2002 and back to 2016 and let ECU Rob continue with his lecture.
Well, that's a little later on. Incidentally, PEEP has not been a paramedic skill for that long. And now it's something that we are starting to do to varying degrees of success. There's some things, guys, that just aren't well suited to the field. It's just all there is. We talked about this in class one night, talking about some paramedics are all gung-ho to do chest tubes. And I'm paramedic, born paramedic bred. When I die, I'll be paramedic dead. But I just don't think that's a procedure that's conducive to the pre-hospital environment. Yes, we may save the patient on a temporary basis, but then it's almost impossible to prevent infection if it's not done. And you can die from infection. Penicillin did not cure everything for us in the realm of infection. That's one of the reasons peritonitis is so dangerous. Sometimes it responds well to therapy, sometimes you die from it, despite treatment. So if we're out there poking chests and sticking tubes, surgically inserting tubes into a patient's chest, and we save them temporarily, well, we may have bought them some time, but ultimately we may kill them from infection. And now if I had one of my people up here that did not share my view on that, they would say, well, if it's done right, well, if my aunt had wheels, she'd be a wagon. If is the biggest. Is it possible to keep in the back of an ambulance, which is not a sterile environment, to keep a chest tube sterile, keep our hands sterile, keep our instruments sterile throughout the procedure? That's the argument. And it's very, very unlikely. Possible, yes. About anything's possible. But it's just not likely. Central lines, I think we could probably do some of the central lines without a problem if we stayed on the venous end. If we're cannulating subclavian veins, things of that nature, I don't think we'd probably get away with that. If we start messing around with, excuse me? Yeah, arterial lines, I think we have a need to do, and that's some of them. The alveoli themselves are about 1 cell thick, very thin. There's a word that you're going to hear used, and I hope I put this close enough where I can use my board, which I probably didn't. You've probably heard it before. God, I hate this board. And I may not be spelling it right. Permeable. Selectively permeable is usually what you'll hear. Permeable just means that things can go through it. And the alveoli of the lungs are permeable. We already know probably that capillaries, something else we talked about that's very important, are also about 1 cell thick, and they are permeable. Let's see if there's any other salient points I want to make sure I get in if I don't do anything else. We talked about neurogenic control. Let me go back and say this. We talked about inhalation, exhalation. We talked about the fact that one requires energy. The other one usually is passive. Inhalation requires energy. Exhalation generally is just when the impulse to inhale is stopped and we exhale. We said that the medulla is the location of the respiratory center. One of the things I wanted you to remember just for practical, there's a lot of aspects of medicine. There is medical theory and health theory, and then there's applied medical theory. And this is an applied thing to remember. Technically speaking, most of paramedicine is applied theory. It's not important for me to understand what's going on at the cellular level. It's important for me to recognize a heart attack and know what to do for it. That's the difference between medical theory and applied medicine. We said that don't know if I even want to go there. We said the medulla was in the respiratory center is in the medulla, excuse me, and it sits low in the medulla, so it may be damaged early anytime the brain swells for whatever reason. And actually, I shouldn't even say anytime the brain swells. I should say that anytime that little compartment, which is your skull and is the cranial vault, anytime that the space in there starts to get reduced from blood, from anything else, oftentimes puts pressure on the brain, and there's nowhere for the brain to go. There's only one opening, the foramen magnum, in the back of the skull where the spinal cord exits. And the brain is a very unforgiving organ. You damage it. It's not like a lot of our tissues which will regenerate. Nervous tissue typically doesn't. It replaces itself with scar tissue. Scar tissue is not brain tissue, and we have permanent damage. We talked about the inspiratory center. We said the expiratory center is usually pretty dormant during normal respirations. It does become active. Scientists don't exactly understand the role of the expiratory center yet. We're not 100% sure by what I can read of what triggers it. I mean, we know that increased labor will trigger it, but we don't know the mechanics of what causes it to work. We talked about the pneumotaxic center in the pons, which has an influence over the inspiratory center. And we talked about the apneustic center, which is active about all the time. It's just overridden by the other areas. So we have a lot of neurogenic control. We haven't talked about how nerve impulses are passed. It's not really germane to this lecture. But we have a lot of nervous control in the brain. We talked about the chemoreceptors and what they monitor. We said that in a healthy individual, chemoreceptors monitor waste products in the blood. This, of course, is also something we'll cover again when we talk about the buffer system, the acid-base system. It stimulates the need to breathe. As acids go in the body, so goes the respiratory rate. If acids go up, respiratory rate goes up, and vice versa. And this is a body's effort to maintain its metabolic environment. Metabolic environment, there's an interesting term. Basically, it's a term that means the set of conditions that need to exist for life to continue. There's a certain range that we have to have. That's what the whole point, and I don't know if anybody ever took the time to tell you about that. The whole point of studying acid-base balance, once you get past the superficial stuff, once you get past the need to understand that the respiratory rate may be increased because the acids are up, the need to understand that goes along with that applied medicine thing that I was telling you about. When you're confronted with a patient whose respirations are higher than normal, it's a way of determining the reason for that, and it may be the only reason. As in, well, a semi-good example would be hyperglycemia. Diabetic ketoacidosis, you'll see a phenomenon called Kussmaul's respirations. And this is what happens when acids have built up in the body to a point, and they're not going anywhere, but the body is responding the only way it can, and the increased respirations and depth of respirations pick up. It's a point of applied medicine to be able to spot that. I have been in situations where paramedics missed Kussmaul's respirations. You get tunnel visioned in on something else, and I've actually seen pretty bad things happen when you miss Kussmaul's respirations. In and of itself, I don't mean to get into endocrine emergencies tonight. If I have to deal with a diabetic problem, I'd rather deal with ketoacidosis. I'd much rather deal with it because you have some time before nasty things that are permanent happen. With hypoglycemia, you're looking at the very real possibility of brain damage if it goes on. All kinds of nasty symptoms from that, like respiratory arrest. Just pick one and you probably could see it. With Kussmaul respirations, as long as you don't do something stupid like what I've seen done, like sticking a bag over their face because you think they're hyperventilating, that in and of itself is not that bad. And there's really not a lot we as paramedics can do except for hydronate. Just start a line of saline because these patients are dehydrated, oxygenate, and get them to some insulin. because generally speaking, that's what they need. Applied medicine, applied medical skills, that's our forte, it's what we do. We talked about chemoreceptors, and they monitor a lot of things, but in this case we're talking about they're monitoring waste. We talked about the baroreceptors, which in this case are a secondary type thing, and this has been challenged by research, but these are supposed to be the origin of the hypoxic drive, which means the people with COPD are thought to breathe from the hypoxic drive, which is the body senses a need for oxygen. And in the olden days, they used to say, don't give COPD patients high flow oxygen because you'll knock out their need. You know, think about it from a practical point of view. If you're breathing solely because you think you need oxygen and somebody just loads you up with oxygen, the stimulus to breathe isn't there anymore. Well, I've got my oxygen, I don't need to breathe anymore. However, this has been challenged by research, and even the moderate members, there's two very big camps, and the camp that says withhold oxygen is dwindling very quickly. Even in the ones that are somewhere between the two extremes will tell you never refuse oxygen to a hypoxic patient regardless, especially at the paramedic level. If they stop breathing, actually in one respect it might be good because I can tube them and I can give them more oxygen, they're going to get on their own. We can deal with that later. They have a little problem weaning them off that respirator later on, but for right now, we've got them. Yeah, I hate to put it that way, but really, guys, I mean, what you said is very true. That ain't my department. That's somebody else's department. I'm just supposed to keep them alive till I get them to the hospital and turn them over to these other people. And if I don't breathe for them, they sure won't be alive when we get there. Let's see what else I've got that was salient before I move on, because what I'm about to move on is the crux of this whole thingy. We talked about atmospheric pressure being expressed by torr. Torr equals 1 millimeter of mercury, generally speaking. I think we said that atmospheric pressure, which is the total of all of the gases that make up our atmosphere at sea level, which we're pretty close to sea level here, 760 torr, 760 millimeters of mercury, and then from that we can break it down into its partial pressures, and we talked about how that was expressed. Sometimes you'll see P, and sometimes you'll see PA. You see P, and it's also expressed as P little a. Partial pressures of the atmospheric gases. We said that total was 760. We have 21% oxygen, which came out to what, 160 as I recall? Excuse me. I didn't really express it, but the value, the partial pressure of those trace gases, one of which being carbon dioxide, is very, very low. It's only about 0.3% of our atmosphere. And I haven't even sat down and figured out what that would be as far as partial pressures. But for the purposes of this class, they're going to be non-existent, really. It's not enough of a factor to worry about. Which brings us to what makes it go round and round. Any questions about that? I know I didn't really go back over the anatomy. I didn't really see a need to. I'm going to move this a little closer. God, I hate this board. Makes me want my PowerPoint presentation that much more. I could sit down and do all this on PowerPoint and just flip through it. Actually, I like a board. Board's a great way to kill time when you wait for people to take notes. It slows me down, and I can let y'all take notes a little better, and I can slow down and write things. We're going to talk about, I do need to review this. We talked about gradients. We said that a gradient is a difference that occurs which causes movement, a predictable movement. I think I used the example of the temperature gradient. The wall separated us from outside, and it was 30 degrees outside and it's 70 degrees in here. The inside of that wall and the outside of that wall are really different temperatures, and what will happen is the concentration, the high concentration of warmer air will move to the low concentration of warm air on the other side, and it will continue until an equilibrium is reached, until the air on either side of that wall is the same. We talked about diffusion of gases. And when we're talking about this for the purposes of this class, guys, understand something. I'm not a physicist. There are literally volumes written on the things that I'm throwing out here in just an offhand manner. There are entire books written on the characteristics of gradients, the characteristics of diffusion, things of that nature. I'm trying to keep it simple because it's just not really relevant to us. We don't really need it. We just need to have a basic working understanding of it. We talked about diffusion being the movement of gases from an area, in this case gases, from an area of high concentration to low concentration. I haven't really, when there's no need for me to, but there's only one other term as far as physics, well there's two, but one only that will come up soon, and that's osmosis, and that refers specifically to water. Water will move from an area of high concentration to low concentration. Actually, usually it's expressed differently. Usually it's the movement of water from an area of low concentration of solute to an area of high concentration of solute. But if you get right down to it, it really works out to be the same. Don't worry about it. That's more of a fluids and electrolytes issue that we'll talk about coming up. Don't worry about it too much. I shouldn't have thrown it out there, but I thought it's the only other term other than force. Force is a physics term. We'll talk about in trauma. The mechanics of normal respiration, and this is, so far we've talked about the structures. We've talked about what we're breathing, meaning that atmosphere and what concentration. We've talked about what makes us breathe, but we haven't talked about what makes us live. We haven't talked about what it is that actually supports life in this process. And that's what we're going to talk about today. It's not really that complicated. If you do understand gradients, it kind of falls into place. I'm not an artist, so I'm not going to try to be. We have an alveoli. We have a capillary. For the purposes of this discussion, we're going to make this the pulmonary circulation of blood, and we're going to say this is occurring in the lungs. There's an alveoli, there's a capillary. Well, there aren't any alveoli anywhere else, but some people get confused about this. When we breathe in, this alveoli expands, and at this particular moment in time, it is filled. It's loaded up with those atmospheric gases. Are we worried about nitrogen? No, not really. What we're worried about is that 160 torr of O2 that is in that alveoli at this time. Everybody with me so far? Just took a breath, our alveoli are just loaded down with oxygen. On the other hand, blood returning from points south, most of them, and the body, are loaded with, they've had most of their oxygen supply depleted. And they have roughly, and there's factors that will affect this, but usually somewhere between 40 and 50. I think the figure I've got out of the book is 46 torr. Of oxygen. This is stuff that didn't get used. This is what little oxygen didn't get used up by the tissues. A lot of factors can affect this. How much work you're doing. How much you're exerting yourself. This is kind of a trivia point, but the average red blood cell can take 4 molecules of oxygen. I don't know where to stick that in your lecture. Write it down somewhere. It's a nice little piece of trivia. I don't know that you'll ever see it on a test. You might. If I really wanted to confuse you, we'd go into diffusion of gases into the blood, excluding the hemoglobin. That's another process that really doesn't contribute that much. Your book mentions it. You can read it. Your book mentions it, and I remember studying it back in school, but it just hasn't come up since. All I remember is it's like, boy, you guys are really complicating this issue. And I didn't see the need for it. On the other hand, as far as our CO2, we have almost none. Virtually nil. Excuse me. I don't think I have that anywhere in here. I don't think I do. Now, since these two are close together, the alveoli are surrounded really in the lungs by respiratory capillaries, we'll call them. And since we said that diffusion occurs, I'm sorry, I got something caught in my throat, guys, it's driving me crazy. On one side of our permeable membrane, we have an oxygen content of 160 torr. On the other side, we have a content of 46 torr. Since gradient does exist, does it not, between these two things, and since diffusion is a process that is a force of nature, we can count on it, what do we expect to happen? Oxygen from this side will move to this side until some sort of equilibrium is reached. Usually we get 80 to 90, depending on the exact figures. And I can't believe I'm doing this because I'm left-handed and I'm writing with my right hand. The rest of the air that's not absorbed is expired out. Now, there are some factors. Does it stop because an equilibrium is reached? Well, no, not exactly. It stops because you might have exhaled. The body's rhythms may be affecting that. Jesus. Guys, I hate to do this. I've got something caught in my throat and I need to get it out. Let's take a break now. I don't know what it is. I was going to, we got some people missing. But I'm going to go ahead and finish up this little part of it right here, because actually you already know the answer. The waste products in the capillary, this will run, depending on your activity, 75 to 80 torr of carbon dioxide. And diffusion, of course, happens there as well. You have an alveoli over here that's full of brand new air and virtually no waste. You have the collected waste from the body, and it will diffuse across that membrane to be expired, the waste products being expired out. Now this cell, having been through this process, is ready to take another journey around the body. I always worry that I'm oversimplifying this process, which would probably be a greater sin or just as great a sin as overcomplicating it. For our purposes, this is gas exchange, made possible by the laws of nature. Diffusion is a spontaneous movement. Osmosis is a spontaneous movement. Any questions about that? Alrighty. Alrighty then.
Ron, probably you said something about the fact that using a piece of glass, bedding on a piece of...
Actually, I was talking about the serous fluid between the two layers of the pleura.
Okay.
And I'll touch on it. You want me to go back over that real quick? Your lungs basically can be looked at like sacs within a sac, both of them. The visceral pleura, the internal pleura, and the parietal pleura, which is the outside. When you look at the pictures and the textbooks of the lungs, what you're usually looking at is the parietal pleura, the outside. Inside, they're hanging inside, the visceral pleura is hanging inside the parietal pleura. Between these two is a potential space, and I call it potential space because in a normal healthy person there is no space. And inside that, to keep those two things lubricated, is serous fluid, fluid produced as a lubricant. And you can look at how it stays together. If you take a pane of glass and put water on it and lay the other pane on top of it, what happens? You can pick them up and they'll stick together. And when we have a problem, which we're going to talk about a little later on, is what happens when that potential space becomes a real space. Then we have a problem. Also, that space can become infected, and we talked about pleurisy. When that space, when you rub together, you get friction rubs there because of inflammation. It's very painful. Oftentimes, we as paramedics will see it in the field, and which is right that you do this, but you'll immediately think cardiac, when in fact it's not. Then there are the veteran medics who will see it and think pleurisy and still treat cardiac because that's the way you cover your rear end, even though you may think and you're pretty sure that what you're dealing with is not your cardiac patient. Where you run into a problem in that situation is you have standing orders as a paramedic to deal with cardiac patients. Oxygen, IV, aspirin, nitro. If you think you're dealing with pleurisy, well, I'll tell you how I always handle it. I did not initiate standing orders and always called medical control and tried to convince them that I was dealing with pleurisy. Because most often, if you can successfully do that, keep in mind, guys, I was doggone sure. I'm looking at a pink patient who's not in the age range to be concerned with, really concerned, young person. Frequently was female. Young females are not the greatest category for heart attacks. They catch up quickly after menopause, but up until that time, they have natural protection unless they have a, I'm not saying it's unheard of for a young female to have a heart attack, but it's very unlikely. They're pink, they're not diaphoretic. They're giving me really weird signs and symptoms like it hurts more. It hurts when I breathe in, but not when I breathe out. The pain is very well localized. They can take my fingers and say, I hurt here. This is where I hurt. Nowhere else. No, right here. Things that you just knew. It's like this is just not what I would be hearing if I was dealing with your cardiac patient. So I was doggone sure. And very, very many times, even the physician, even with me being sure, even me telling them, they'll still say, carry out your cardiac protocol.
But you would call medical.
I would. If I really thought I was looking at pleurisy, if I really thought I was looking at something like that, I'll tell you this, if there was that much doubt, go ahead and I'll treat cardiac and let them sort it out. But if I'm sure, and I have been sure, I've had 23-year-old girls who were pinker than I was, weren't diaphoretic, no congenital heart problems, which in females it just about has to be a congenital heart problem before you start having cardiac problems. And scientists believe it's estrogen. Guys are doing experiments with estrogen now to prevent heart problems. And the reason they're almost certain, one of the reasons they're almost certain that estrogen is a factor is because after menopause, women catch up with men almost immediately. A postmenopausal woman can become a risk for heart problems very quickly. But they just well-localized pain, and it wasn't substernal. It was almost always lateral somewhere. And I just knew that there was no point in me. Oh, coupled with another thing that kind of gave me ammunition. Young females frequently have mean blood pressures around 110, 100. My ex-wife, her blood pressure never ran 86 a day I ever knew her. 86 systolic was her normal blood pressure. You find that. So that kind of got me off the hook with the nitro. I wouldn't give nitro anyway. But sometimes that would give me some ammunition. Doc, this patient's borderline hypotensive as far as our nitro protocol, and then I would go into all this other stuff. I liked it a lot better when I could talk to him on cellular phone because you let your hair down and just lay it out. Say, look, Doc, I don't think I'm looking at a heart attack. That's why I'm calling you. I think I'm looking at pleurisy or something like that, and I really don't think that this patient's going to benefit from aspirin and nitro. Now, some physicians will turn around and say, well, you're probably right, but go ahead and give it to them anyway. It's not going to hurt anything if their blood pressure will support it. Go ahead and do it, cover the bases, and bring them in. Frequently, though, if they knew you, and most of the ones where I worked knew me, they would say, well, just, you want to start a line? Yeah, we'll start a line on her, but can we just bring her in? And that's pretty much what we got. I would always put them on the monitor just in case I was looking at some congenital heart defect that and there's a lot of them. There's all kinds of heart diseases that can really pull a fast one on you and you not know it. Congenital problems that people are born with. who knows? It's rare, but maybe they're showing the first stages of, well, any number of diseases. I started to say it could be in the first stage of WPW, but I'd probably pick up on that. You should be able to pick up on that. Having explained that, I don't want to go there. I guess, and I really didn't want to do this now, but I guess I'm going to have to start it. I'm going to talk a little bit about, we've talked about what happens when it goes right. Let's talk about what happens when it goes wrong. If you stop and think about it, there's really only 3 reasons why somebody is not breathing well. You say, oh, Rob, that can't be right. There's hundreds of reasons. No, there's only basically 3 reasons. There's a mechanical problem, which means there's a problem having to do with the anatomy. Something's wrong with the machine. And this is very much applied medical theory. If you're confronted with someone who cannot breathe, you can stop and think to yourself, well, there's only 3 reasons why they're not breathing. Something's wrong with the machinery, mechanical. We're going to talk about all the sub-reasons, but the main reason is whatever they've got, asthma, emphysema, chronic bronchitis, whatever condition they have, something's messing with the machinery. There are neurological reasons. That's the second reason. Well, the machinery's okay, but something's wrong with the computer that tells it to work. And this can be everything from an actual brain injury, CVA, traumatic head injury, to drug use. Drugs are involved that are telling the respiratory, like narcotics. What is one of our major one of our major concerns when we give any type of narcotic? What immediately comes to mind is morphine sulfate. Is keep an eye on the respiratory rate, because it will depress that. And the third one, I almost hesitate to mention, but it's a combination of the first 2, which is rare. It's rare that you have a combination of both mechanical and neurogenic or neurological problems which contribute to, but it can happen. You've got multi-system trauma, who knows? Most of these conditions scare me. And very few things will get my heart going faster than a true respiratory distress patient. Anybody care to venture a guess as to why? Well, I'm going to go ahead and tell you, as paramedics. People with chronic respiratory problems live with these problems. They've had them for years. They know it's going to be a problem for them. When you pull up in your handy-dandy aid bag in your truck, ready to save the day, and you walk into these people's houses and you look on the nightstand beside the bed where they're sitting bolt upright, using every muscle they've got to get air in and out, you're going to find the same drugs that I'm going to open up my kit and get out. That's one thing. I have a few little tricks up my sleeve that they may not have. It depends on where I'm at. Some services don't carry the drugs that I've used to carry, and some do. I can tell you right now, with the exception of one drug, they had most of my chronic respiratory distress patients had every one of the same things I carried on the truck, with the exception of aminophylline. It was the only drug that I had, and getting an order for aminophylline was like pulling eye teeth, because the effects that it had on, you monitored, do flip-flops, jump off the bench. It was something you really had to keep an eye on, and most physicians did not want to just give you a shotgun order for aminophylline. When I say a shotgun order, I mean jump straight to aminophylline. Don't go through the steps. Most of them would take you right back through the steps, give this drug, if that don't work, give this drug, and by that time I was at the hospital and the patient either lived or died in the transit. The only time I would ever even consider using aminophylline was when I had this situation. I walked in, I looked at their nightstand, they've sucked 5 albuterol inhalers dry, they've got an old drug, but sometimes you'll still see it, bronchosol. They've got all of these things that I've got in my pack, and it hasn't worked. They live with it, so if they've called me, something about this episode is different. These people most of them, your normal, but get sick of hospitals. If they've called me, you best believe something has spooked them. Because they live with this every day. I mean, you see them walking around with their O2 tanks at home, and they never take it off. And then they've got, you check their pajama top, there's 4 inhalers in there, and they get through the day. But then that one time it happens and they feel, I can't handle this, I'm going to die, and they call me, and then I get there and I've got the same stuff. Which is one reason why I'm glad to see rapid sequence intubation become part of our skills. Because I have had many patients that needed to be taken down in tubes. They couldn't move air well enough, and I didn't have anything to fix it, really. So respiratory, I'm talking about respiratory stress as one patient. If someone would ask me it's not multi-trauma. Trauma, I hate to bust people's bubble, at least in my opinion. Trauma's easy. It's all laid out for you. Your steps are laid out for you. Now you may have an opportunity to do something interesting, decompress the chest or whatever else, but basically it's airway, C-spine, breathing, circulation, stop major hemorrhaging, reevaluate, and rapid transport, because they're probably going to have to need surgical intervention, and we can't do it. So I know a lot of medics who are trauma junkies. They live for trauma. I don't find trauma to be that challenging. I just don't. It's laid out for me too well. Medical calls. Playing medical detective is much more. Trying to figure out what in the world is going on here is much more challenging. Respiratory would be the one I would tell you that scares me the most. Because invariably these people are conscious too. And they're looking to me to help them. And frankly, I don't know if I've got what I need to help them.
You're saying you can intubate these patients?
Yeah, with rapid sequence, if we have a patient that is not responding to let me clarify that. We have a patient who is in deep respiratory distress, actually probably in the end stages where they're starting to wear out, where they're starting to decompensate, and they're not responding to the drugs that I have. It's a wonderful thing to be able to take them down and tube them, and then I can breathe for them. That's what rapid sequence is all about. The only bad thing about it is, it's what you're saying and what you're doing is banking that you're going to get that patient tubed. Because they will not. They have no way of protecting their own airway once you give them these medications. That's it. Everything is paralyzed but their heart. And once you do it, you're banking that you're going to get a tube in. And if you don't get a tube in, you're praying that they don't vomit and aspirate.
Do you need written permission to do this?
You won't need written. You'll need a lawful order from a physician. I don't know. I'm going to tell you right now, under Dr. March, if you were under Dr. March, I got a feeling you'll have a standing order to do it. Because and I understand his reasoning on it and agree with it. If you come to think of it, guys, rapid sequence is not something you want to be tied up on the radio trying to get an order for. I mean, it needs to be done now. It's not something that I want to call in and say, I need to speak with a physician or MICN, stand by, because it's busy there, and they're walking through the ER trying to find somebody for me while my patient dies, because I don't have an order. It's something I need to do now. And
It could take 5 minutes waiting on the phone.
absolutely. I've had them forget about me. I've had people forget I'm sitting there on the radio, waiting and waiting and waiting, and finally get frustrated and put it up. But, hospitals get busy. They get busy. One of the main reasons we have MICNs is because somebody finally figured out that the physician might be occupied when you call in for orders. So we have somebody else we can get orders from. MICNs get busy. I remember the hospital, Annie Penn Hospital, we had 2 MICNs on staff, but it was a small emergency department. It didn't take 5 or 6 patients, and every one of them had somebody to deal with. And when you called in, the MICN's not going to say, let me stop in the middle of holding this arterial bleed while the ER doc tries to suture it to come talk on the radio. It's not going to do it. So I imagine that rapid sequence will be a standing order thing. They will be watching it closely, I'm sure. Keep in mind, guys, we always have to contend with the I'm doing this because I can people. And if we do that too much, then they'll either take it away from us. How many of you knew that many years ago, pericardiocentesis was a paramedic skill? That's heavy.
What is it?
It's taking a big old long needle. Actually, it wasn't, in a real sense, it wasn't pericardiocentesis, it was intercardiac injections. Paramedics were trained to give medication directly into the heart.
So nice.
It's a radical thing because there's so many chances for complications. And eventually it just kind of went away. Mainly not because we were screwing it up, but because, I mean, I worked with guys that had been in the business long enough to have done a few of them. They'd done a few intercardiac injections. Most of the epinephrine you guys have probably seen did not have, probably had a regular needle on it. Well, a lot of the stuff that we carried for the longest time at Rockingham had the intercardiac needle still on it. I don't know if they're still even packaging it that way, but you had a needle on it that long. You pull it out of the box, and there was a needle attached to it that was this long, and that was what it was for, intercardiac needle. We found that there's a lot of, well, there's one primarily really good reason for not doing it. If you don't make it into the right atrium, which is what you're shooting for, if you put it in the myocardium, they go into irreversible fib. You can't get them out of it. We also had punctured lungs, lacerated livers. Oh my gosh, what were the list of complications? But it had to be done right, and it just something that somebody finally said, you know, they don't need to be doing this. There's too many other ways of gaining vascular access. We don't have to. Granted, it was quick. Take it out of the box, straight into the heart. Anybody in this room, hospital people included, ever seen an intercardiac stick? Ever seen it done? You don't see many people even see it done anymore. They don't even do it that much in ERs anymore. It's just too many other ways of getting vascular access. Cut down, central line insertion, peripheral canalization, sternal needles, which you don't see much of that either, but it's possible. IO's made a comeback now for kids. So, you know, you don't see it, but it's still out there.